You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about differentiating the Doppler envelope of aortic stenosis, mitral regurgitation, tricuspid regurgitation, and hypertrophic obstructive cardiomyopathy. When performing CW Doppler at the left ventricular outflow tract and aortic valve area, it can be tricky to tell whether you are picking up on the aortic stenosis signal, the mitral regurgitation signal, the tricuspid regurgitation signal, or a dynamic LVOTO obstruction signal from HOCM, since all four of these occur during the systolic part of the cardiac cycle. The board exam will unfortunately remove the 2D echo thumbnail, depriving you of the location of the CW cursor location that you would have access to clinically if you were to do this in the hospital. Outside of the board exam, it is necessary to know as well because you need to be able to identify when there is contamination of signals, for example, if MR and LV outflow tract obstruction signals are being superimposed onto each other. And also because images from the PDUF probe do not come with a 2D echo thumbnail. So I think this is a very important and worthwhile topic. So let's start with how do you distinguish between the CW Doppler of aortic stenosis versus mitral regurgitation. First, aortic ejection flow begins after the QRS complex because it needs to wait for the isovolumic contraction time, IVCT, before the aortic valve can pop open. The IVCT is the gap of time between the mitral closing and the aortic opening. Mitral regurgitation does not need to wait for any sort of isovolumic contraction time and can start falling back into the LA right after mitral closing. So if you see the envelope start at the S wave, it is the AS jet. If you see the envelope start at the peak of the R wave, it is the MR jet. Second, the aortic stenosis jet is of shorter duration than the mitral regurgitation jet. The maximal duration of an aortic stenosis jet is the point of aortic valve opening to aortic valve closing, which is not as long in duration as the time from mitral valve closing to mitral valve opening. Remember that there is a gap called the isovolumic relaxation time that separates the aortic valve closing and the mitral valve opening. For both of these reasons, the mitral envelope in systole and diastole can blend into each other, whereas with aortic stenosis, there should be a distinct gap with no envelope during the IVCT and IVRT. Third, mitral regurgitation should have a higher velocity throughout ejection and a higher peak velocity compared to aortic stenosis because the LV-LA gradient should be usually higher than the LV-aorta gradient. That is how to distinguish the CW Doppler of aortic stenosis versus mitral regurgitation. Next, how do you distinguish the CW Doppler of aortic stenosis versus tricuspid regurgitation? First, aortic ejection flow begins after the QRS complex because it needs to wait for the isovolumic contraction time, IVCT, before the aortic valve can pop open. Tricuspid regurgitation does not need to wait for any sort of isovolumic contraction time and can start falling back into the right atrium right after tricuspid closing. Remember that tricuspid closing occurs before mitral closing, so the TR envelope actually starts at the Q wave even earlier than the R wave peak that the MR envelope starts at and the S wave that the AS envelope starts at. Second, the AS jet is of shorter duration than the TR jet. The maximal duration of an AS jet is the point of aortic valve opening to aortic valve closing, which is not as long in duration as the time from tricuspid valve closing to tricuspid valve opening. Just like as discussed for the MR envelope, the tricuspid envelope in systole and diastole can blend into each other, whereas with aortic stenosis, there should be a distinct gap with no envelope during the IVCT and the IVRT. Third, tricuspid regurgitation should have a lower velocity throughout ejection and a lower peak velocity compared to aortic stenosis, except in cases of severe pulmonary hypertension or in cases of non-tight aortic stenosis. Next, how do we distinguish the CW Doppler of aortic stenosis versus the LV outflow tract obstruction of HOCM? The envelopes of aortic stenosis and LV outflow tract obstruction in HOCM both start at the R wave after the isovolumic contraction time. In both of them, the base of the envelope lasts from the aortic valve opening to the aortic valve closing. The primary way to distinguish them is by their morphology. The LV outflow tract obstruction will look like a saber tooth or a dagger, corresponding to what point during systole the LVOTO obstruction is maximal, since it is a dynamic obstruction. The velocity is low in early systole and peaks or troughs near end systole. Then, how do you identify overlapping mitral regurgitation and LV outflow tract signals in HOCM? It is possible for HOCM patients to also have mitral regurgitation. A single image can have both components. If you fail to realize the presence of an overlying mitral regurgitation signal, you will overestimate the LV outflow tract gradient. First, remember the velocity of the mitral regurgitation is always higher than the LV outflow tract velocity, because the former gives you an LV to LA gradient and the LA pressure is typically low. So the mitral regurgitation envelope typically is deeper than the LV outflow tract envelope. Second, the morphology of the mitral regurgitation envelope is curved initially but then straightens out perpendicular to baseline by mid-systole, whereas the LV outflow tract obstruction will look like a saber tooth or a dagger. Is it possible to distinguish HOCM MR from non-HOCM MR on CW Doppler? Yes, in fact. HOCM is characterized by the eject, obstruct, leak sequence. HOCM's MR occurs as a result of systolic anterior motion of the mitral valve that impedes coaptation between the two leaflets. Non-HOCM related MR, except for MV prolapse, will have their onset right from the start of mitral valve closure without waiting for the isovolumic contraction time, whereas HOCM's MR will wait until isovolumic contraction time is done before it starts. Finally, how do you distinguish between valvular AS from subaortic membrane? If you see elevated transaortic valvular gradients but normal appearing aortic valves in a young person, suspect subvalvular obstruction, which can occur from a subaortic membrane. It is difficult to differentiate valvular AS from subvalvular AS, for example, subaortic membrane, based on just the CW Doppler alone. To figure out if AS is subvalvular, apply color Doppler and see if aliasing of the velocity occurs below the aortic valve, suggesting that flow acceleration is occurring at the subvalvular level. You can also do PW Doppler to figure this out. So now we have covered distinguishing between the Doppler envelope of aortic stenosis, mitral regurgitation, tricuspid regurgitation, and hypertrophic obstructive cardiomyopathy. I hope this will come in handy someday.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.